And so next we have is Lauren Bovitz, is a cancer genetic counselor as well as a cancer genetic counseling manager at the Cleveland Clinic. She graduated with her Master's of Genetic Counseling from Case Western Reserve University in 2015, has been with the Cleveland Clinic since 2021. She sees a variety of patients and specializes in pediatric oncology and precision oncology, and is proud to be a part of a team of 14 cancer genetics counselors. So thank you very much. And she's going to talk about how genetic testing can be helpful to patients and families with neurofibromatosis and schwannomatosis.
All right, good morning, everyone. I'm happy to be here with you virtually today. So again, my name is Lauren, and I'm a cancer genetic counselor here, and I'm going to be talking with you all about genetic testing and when it is and may not be helpful. And so let's all go back to high school biology here. So if you think about our cells, we have trillions of cells in our bodies. In each cell, we have all of our DNA packed into chromosomes. If you unwind that spool of thread that is a chromosome, you get a strand of DNA, and along that strand are various genes. Each gene is made up of hundreds or thousands of genetic letters called nucleotides. If you ever see a genetic test report and you see lots of G's, C's, A's, and T's, those are our genetic letters. And just so the talk makes a little bit more sense, so you sometimes hear people say, oh, I have the gene, I have that gene, and we all actually have 2 copies of each gene. We all have over 22,000 different genes, and we don't even know what half of those do. And genes make proteins, which then have a biological function, basically a job in our body. So when we're doing things like genetic testing, we're looking for mutations or a misspelling in those genetic letters that causes the protein not to work, which then can increase the risk for different health conditions. So what is genetic testing? We'll go into some of the nitty-gritty later, but typically it's a blood or a saliva test that is analyzing someone's DNA to look for those changes or mutations. The goal of this is to either confirm or rule out different genetic conditions. It can then inform somebody about their different risks for medical conditions and help figure out if relatives may be at risk as well. And so who are genetic counselors? Who am I? So genetic counselors are specialized healthcare professionals, and we receive a lot of training in medical genetics and counseling skills. Genetic counselors are there to guide and support patients that are looking to get more information about these different genetic conditions, and especially genetic counselors are very helpful in interpreting genetic test results, including what those results can and cannot tell us. My big caveat is that we are not doctors. I did not go to medical school. GCs have a master's degree. Our training programs are typically 2 to 3 years. We are board certified, and many states offer licensure, but again, not a doctor. I can tell you all about genetics, not much about anything else. And so how do I get genetic testing? So typically you would meet with a genetic counselor and possibly a geneticist. The geneticist is the MD there. And in those visits, we're collecting medical history and family history. We are sometimes offering a physical exam if needed. We determine the extent of testing, the cost of testing, and then it's always an option to move forward with testing. It's by no means mandatory. Patients then go to the lab for a blood draw. We can also send a cheek swab kit if you don't want to poke, and that gets sent right to your home address. Once the sample is obtained, results take about 2 to 3 weeks, and your genetic counselor would review the results with you. And in genetics, we're always first thinking about what the results mean for the patient, but what it means for the family as well. And what kinds of results could I get? So the first result is a positive, and that is when we find a gene mutation that would have implications for both your care and your family's care. A negative result is when we don't find any genetic misspellings. My big caveat here is this does not mean you do not have that genetic condition. It just means we couldn't find the mutation that caused it to happen. This last one seems complicated, but I promise is not. So we can also get what we call a variant of uncertain significance. And that's when we find a change in the genetic letters in one of your genes, but we don't have enough information today to say if that change is harmful or harmless. For what we're doing, most of these uncertain results are reclassified as harmless in the future, so we don't make any changes to a person's management if they get an uncertain result. I give the example of the word cat. If you misspell the word cat, K-A-T, yes, it's a change in the gene, but you still know what that word is. So when is genetic testing helpful? And I will start by saying it may not be. So a lot of genetic conditions can be diagnosed clinically based on your personal or family history. So I've included some examples here. So, things like for NF1, cafe au lait spots, freckling, neurofibromas. With NF2, we're thinking more about those schwannomas. And I say that because, again, a clinical diagnosis is a clinical diagnosis. Even if genetic testing comes back normal, where we do not find a causative mutation, your doctor would still recommend the appropriate follow-up screening based on your clinical diagnosis. And so why am I talking to you? So really the main reason is that there can be overlap in some of the features with different genetic conditions. So if you take cafe au lait spots, yes, we can see those in NF1. You can also see them in less common conditions like Leigh syndrome, a condition we'll talk about a little bit more later called constitutional mismatch repair deficiency. Same thing with schwannomas. We used to really think NF1 was the main cause. Today we've identified other genes that can cause those schwannomas. And so again, why am I talking to you? So sometimes the genetic testing can be helpful. The testing can help clarify what your diagnosis is. And the risk for various tumors or other health conditions differ with each condition. So if we know exactly what's driving your tumors or your health issues, we can offer the appropriate screenings. We want to make sure we're not over or under screening you. Again, if we find a genetic cause for your disease, we can also then offer testing to family members. We can offer, the future of medicine is precision treatment, as you've heard about. So some medications or studies may require a genetically confirmed diagnosis. And so let's talk about how these things run in families. So most conditions we're talking about today, they're inherited in an autosomal dominant fashion. And that means that they can be passed from mom or dad to a child, and each child has a 50% chance of inheriting the mutation that their parent has. And so I put together a couple pretend families here just to walk through some of these ideas. So let's pretend I saw this 35-year-old woman who was diagnosed with NF1 in her childhood after she had multiple cafe au laits and neurofibromas. In the past, she didn't have genetic testing. She had her clinical diagnosis. It wasn't going to change her management, but now she has 2 young children and wants to know if they're at risk. So we test the patient, we identify a mutation in the NF1 gene, confirming her diagnosis. Her children have no features of NF1, but they're still young, right? So we could offer them genetic testing to see if they're at risk to develop any of those health issues associated with NF1 as they get older. So what else should we know? So we know that about half of people that have NF1 have a de novo mutation. And de novo, Latin for new. And basically that means that the mutation happened brand new in that person and was not inherited from a parent. These mutations then can still be passed on to their children, but it can't explain why there's no family history of the genetic condition in the family. So again, back to our pretend family. So we have our patient who has the NF1 mutation. We test her parents. They do not have the mutation. Most likely, this means that the patient has that de novo or new mutation in herself. What else should we know? So this idea is a little bit more in the weeds, but I'll tell you why I'm going through it. So there's the idea of gonadal mosaicism. And this is when a mutation is present in a person's sperm or egg cells, but nowhere else in their body. They would not have any features of NF1, but the family members could be at risk. So if we go back to our pretend family, again, her parents were negative, but then her younger brother tests positive. How could that happen? That could potentially be related to gonadal mosaicism in a parent. Again, no clinical features, but then children are at risk. What else should you know? So somatic mosaicism. So, if you're seeing the image there, so mitosis is the process of cells growing and dividing. And so occasionally what can happen, so after the sperm and egg come together to create the zygote, as those cells are growing and dividing, a random mutation can happen in one cell. As that cell continues to grow and divide, we're seeing that mutation in more cells. And so that can sometimes mean that there's the mutation in parts of the body, but not all of the body. Before I mentioned that testing is usually done on blood or saliva, that is usually the easiest way to do testing. If that blood or saliva tests were negative, though, we may need to consider doing further testing. And so pretend family number one-ish. So let's pretend she had the blood sample and we did not identify an NF1 mutation. We can then offer testing to a quote-unquote affected part of the body. So if we're thinking about NF1, we could it's a very quick process to do a little skin biopsy. If there's a tumor, we can offer tumor testing and look to see if there, again, is a mutation in that affected body part. If a mutation were identified with that tumor testing, we wouldn't need to test her parents or siblings because, again, this is something that we thought happened after the baby formed. We would still recommend testing to her children, though, because we just can't say if the mutation was present in her egg cells. Okay. And so I also like to talk about recessive inheritance. A different genetic condition that we talked about earlier is called constitutional mismatch repair deficiency. This is not a common diagnosis. It's caused by mutations in 5 different genes. And the reason I bring it up is that there is some overlap with a condition like NF1. We know CMMRD can cause cafe au lait, but not neurofibromas. This condition can increase the risk for children to develop cancers. Parents are carriers, but they're actually affected with a condition called Lynch syndrome that causes adult cancer risks. Anytime both parents have Lynch syndrome, each of their children has a 25% chance of being affected with CMMRD. Okay. Pretend family number 2. So let's pretend we have a 5-year-old girl whose pediatrician noticed the cafe au lait and referred her to genetics. Her NF1 testing was negative. Should we be done with our testing? Well, a genetic counselor would look at that family tree and say, wait, we do have some cancers at younger ages in the family. She has a paternal grandfather with colon cancer in his 40s, maternal grandmother with uterine cancer in her late 30s. That's not really what we expect to see in most families. And so given that family history, I would recommend further testing for that child. Again, both NF1 and CMMRD can cause cafe au lait, but the risks for, the cancers and tumors really differ. So it's helpful to know exactly what that child's diagnosis is to then make sure we're recommending the appropriate screenings. Again, pretend family genetic testing of the patient confirmed that diagnosis of CMMRD, where she does have a mutation on both copies of her PMS2 gene. Since we get one gene from mom, one gene from dad, we can assume that mom and dad are both carriers of one PMS2 mutation. We have then pediatric cancer screenings that we'd recommend for the child, and then we have adult screenings that we'd recommend for the parents as well. So all of the other presenters, please don't get mad at me. If you or your child has cafe au lait and neurofibromas, they very likely do not have CMMRD. So even in genetics, where we deal with very rare conditions, CMMRD is 1 in 1 million children. This is a very rare condition. NF1 is much more common, okay? I use this as an example for why sometimes we're looking for those rare things to make sure that we really have our diagnosis correct. All right, last couple minutes here. So if you really want to impress your genetic counselor when you meet with them, here are the last couple things I like to mention. A lot of patients ask me, me, my child, my sister, we all have the exact same gene mutation. Why is everything so different for us? And so in genetics, we have these two ideas of penetrance and expressivity. Variable expressivity. And so penetrance is kind of a yes or no, right? Do you have the features? Yes or no. NF1, as an example, is virtually 100% penetrant. People that have the diagnosis of NF1 will have some feature of the condition. The variable expressivity is more of a sliding scale, right? How minor or severe are your symptoms? How likely are you to get those symptoms? And each person with the same exact genetic condition, the same exact mutation in a family, they don't all experience the same symptoms, right? And so if you have any, if you have a family member with the same diagnosis, that's why it may look very different from person to person. My bad joke is that I have very good job security because we really don't understand why yet. And maybe in the future, we'll have more information to help families predict what kind of symptoms they should be most concerned about. And if you have any questions for me, I will be on the panel later. If you are a Cleveland Clinic patient and would like to meet with a genetic counselor, your provider can put that referral right in Epic, and we are happy to see you and answer any questions you have. Genetic testing is never mandatory, but we're always here to answer any questions if you have them. Thanks so much. It was a pleasure to meet with all of you today.